Roundtable. So as most of you know, my name is Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. I'm joined by my colleagues, David Sharp and Anena Anyabo. Dr. Pat Zapp will be facilitating the discussion. So please contact Kelly Scott or send a chat message if you're having technical issues. You should have received an email earlier today with her contact information. And right now I'm going to just call roll for the participants. So Dr. Bazinski.
Here.
Dr. Conway.
Present.
Charles Gazzara.
Here.
Cheryl, I don't want to murder your last name, so.
Gasagio. Yep, I'm here.
Emily.
Here.
Let me see. Is Dr. Kana on the line? I'm not sure if I see.
Yes.
Okay. Hi, Dr. Kana. How are you?
Hi.
And Doug Spots.
Yes, I'm here.
Great. Thank you so much. So thank you for joining all of us. Did I miss anyone who's on the call? I think I got everyone. Okay, great. So I'd like to just review the approach for the meeting. So the Maryland Healthcare Commission convened this roundtable with representatives from advanced care delivery practices to identify challenges and opportunities for practices that are seeking to address key health equity concerns in their communities. The roundtable discussions will inform the development of health equity resources for practices, such as information briefs or learning symposiums. And the tables that we're going to discuss today that we sent ahead of the meeting are designed to identify those practice resource opportunities to address the challenges that we discussed. So at this time, I'm going to turn the meeting over to Dr. Zapp to facilitate that discussion.
Hi, everybody. Good to see you again. Thanks for joining us. And last time we promised there would be more time to talk, so I'll be brief. I did want to just give a quick recap and remind you also, since it's a roundtable, I'll be using your first names. Of course, call me Pat. At our last meeting on March 30th, it was sort of a level setting meeting. I'm looking at my notes. We discussed health equity definitions, what success might look like when health equity is achieved, and what the business proposition is for practices engaged in achieving health equity for the communities. Sarah, Ken, Angelica spent some time identifying individual autonomy, personal definitions of health. Monica and Tim highlighted the importance of community partnerships to help historically marginalized populations overcome fear and distrust of the medical community. Monica and Tim and also Cheryl acknowledged that reducing both the total cost of care and health disparities can be achieved only when social determinants of health are addressed. And specifically, Cheryl said that really we need micro and macro tactics and initiatives to address health inequity. And Doug chimed in as well with some remedies of his own. As we go into next steps for this roundtable discussion, we're going to move from talking about these concepts and level settings to where do we go from here. And as part of that, we shared with you the results of a survey done in February of this year. 1,500 clinicians were surveyed across the country. 2/3 of them were specialists, 1/3 primary care. Almost all of them identified social determinants of health getting in the way of care. Almost all of them identified they wanted to do this work, and many of them identified trying to address these social determinants of health as a source of burnout. And as Ken said so eloquently at the last meeting, we really want to do this work, we just need practical help. And that's really the purpose of this roundtable, is to get your ideas, your advice on how do we help practices. Specifically, what success for us in this roundtable looks like is that we make recommendations that are going to inspire and support practices so that they sustain and even expand upon their efforts to achieve health equity. So as we're discussing these topics, I would ask you to keep in the back of your mind. You don't have to answer now, but what does that help look like? What would help the independent practice, specialist or primary care, small or large, employed or unemployed, or not employed, I should say? Does this look like a durable learning material? Does it look like a lecture? Does it look like a learning opportunity that's shared? What does that look like? But as we move forward from talking about what health equity looks like and where we need to go in terms of helping practices, we need to start thinking about certain topics. You saw the questions that were sent out. And one of the things that all practices that are interested in achieving health equity need to do is measure, right? So they need to say, where are we now? Okay, let's implement something and let's remeasure and see where we are. So part of that data gathering effort is just getting personally identified information on race, ethnicity, gender, preferred language. So I'll ask Ken, because he's out there doing this all by himself, I think is how he described it. And what is being done now in your practice and in primary care practices in general to gather that kind of data, race, ethnicity, preferred language, so that you can start measuring disparities in care as well as disparities in outcomes?
Well, I mean, those are just some of the fundamentals of data gathered on patients. If it's not gathered on every patient in my practice, it's an oversight. It's something that we should gather, but we gather it, and that's kind of about it. There's no incentive, motivation, or way to tie that data or analysis of that data into care decisions or treatment plans or anything beyond that. So it's data we dutifully collate, but there's nothing to do with it. Here we're very homogenous out here in the West. Preferred language is, it's very, very rarely do we have anyone whose preferred language is anything other than English. We have other social determinants of health and disparities, but that's not one of them. I have a lot more thoughts. You really triggered a lot of thoughts, but I'll answer your question, stop there, and see what other people have to say.
And a follow-up question for you. So you're on an EMR, correct?
Oh yeah, yep.
And for example, could you pull a report comparing, breast cancer screening rates for different races in your practice? Could you do that or not?
Yes, we could. We could.
Okay. All right. So there's that capability. And I think in Maryland, as Melanie has reminded me, we are a state of small practices, many independent, and that goes for specialty as well as primary care. And a lot of these independent practices have joined networks like Privia, for example, or Clinically Integrated Network for the purpose of, many purposes, to share resources, but one of those resources is EMR, and it's hard to do this work without EMR. I think it's almost impossible. So that's the good news, is that even though we have these small independent practices, which are a good thing to have, they can share resources. So that's helpful. Let me ask Niharika, how easy or difficult is it to have practices gather data, whether they're primary care practices or specialty care practices? And I mean real data, REAL.
So what you've got on there is very basic demographics. I would add regular address to that as one way of identifying homelessness. And I might also suggest in front of gender, we should have how they want to be referred to. These days, we are seeing more and more people who have who like to utilize other gender. So they'd like to be referred to in their preferred gender. So we want to make sure that we're respectful to them. And I think in terms of collecting this data, it's understandably self-reported data. So therefore the race, ethnicity, gender will be the patient's preference, which is fine. I mean, it doesn't necessarily mean that that's what they were when they were born. But I think a very important thing to include up there is a regular address. And I've been thinking about how would you collect this homelessness data? And I think one way might be to ask the individual how long they've lived at that particular address. That I think would give us a sense of whether they're couch surfing or temporarily living somewhere. And I think homelessness opens up a huge field where a lot of health issues can begin to be addressed. So I think homelessness is very, very important. And I didn't see zip code on there, but zip code is another good way for us to identify those individuals who live in underserved, underprivileged domains, and specifically in Baltimore, where we have areas of persistent poverty. And that persistent poverty clearly correlates with multiple chronic diseases, obesity, increased cancers, decreased access to care, sort of the works. So I think to answer your initial question, is it hard to collect? No, it's not. I think most primary care practices are really good at getting demographics, but I think the fields in the demographics section need to be enhanced with gender and how you want to be referred to, and also address and how long you lived at that one particular address. I think that will give us some valuable data.
Thank you for that. And certainly this kind of goes into the second question, which is screening for social determinants of health. Shelter is one of those, poverty is another, literacy, et cetera, et cetera. So, and I want to just for a second hold off on screening for social determinants of health. I just want to focus basically on, do we as a group think that most practices are either collecting REAL data or can get it from someplace else? And Cheryl, I know you have to leave early, so I'm going to ask you, are there other data sharing efforts that can be leveraged? For example, if people are on a shared system or even just using CRISP, can they get those data points and import them, or at least have access to them at the practice level?
Yeah, I mean, I think there's been movement on asking the social determinants of health questions, and then taking action on any sort of concerning results that come as a result of that. But I don't think we're there, at least not in our health system and in our area. As part of like the NDPCP initiative that has been, grown into some of those workflows, but I don't see that we're consistently there yet. Even quite frankly, on the hospital side, where there are a lot of assessments going on, we're not always asking all of those social determinants of health questions, nor are they consistent. There are lots of different types of assessments that are utilized. Some are really, really lengthy. Some are very brief. Some hit certain areas and miss others. So I think there is kind of a lack of consistency or a way to synthesize all that information together and then pass it along to other service providers that are involved with the patient. I do think in our EMRs within CRISP, they're building some of those capabilities, but I think there's still work to be done.
There definitely is. And I think you've also addressed the reliability issue, perhaps indirectly. Sometimes the information can be gathered incorrectly, especially if it's not using self-identified. And we've seen that in the hospitals a lot. People kind of look across the counter, figure out what race are you, and put something in. So it seems like the group's kind of morphing toward SDOH screening, which is great.
Hey, Pat, can I ask a clarifying question? You mentioned real data, REAL. Does that stand for something?
Yes,
That's new to
race,
me.
ethnicity, and preferred language. And that's just a really rudimentary, thank you for asking the question. It's just a really rudimentary way of stratifying your quality results, just to see if there are some disparities. And then the social determinants of health screening is, of course, all those factors that do affect health. Race is certainly built in there, but as Niharika said, homelessness, definitely poverty, literacy, all those issues. So thank you for asking that clarifying question. And I think that it's, we've certainly had some, as a medical community, we've had a couple years now of experience of collecting REAL data. And I think we're just now dipping our toe as a group in screening for SDOH. And I'm going to ask Doug, in your health system, what efforts are underway to screen for social determinants of health in any care setting, whether that's in the hospital and primary care and specialty care?
Yeah, no, great question. Lots of thoughts. I'll tell you that we've done a lot of work prior to the pandemic. We went live with Epic probably about a year and a half into it when the pandemic hit. It probably catapulted us ahead faster, like many people, on a number of living into sort of the ambulatory modules. So we know, for instance, we had Healthy Planet, which is sort of their social determinants platform. And there's so much that you can do and that you pre-purchase. But we also felt that it was very nurse navigator, care navigator dependent. And we wanted to make it accessible, that it was patient facing, and that any member of the care team, from the front desk to the clinician to the care navigation nurses, could do it. So we took the social determinant questions and we sort of, I'll say, skinnied them down to 6 questions, leading in with 1, do you ever feel lonely? And sort of capturing loneliness, because that in and of itself, if the answer is yes, can take you down many pathways or show that that person's at significant risk. Do you ever feel, I'm doing these off the top of my head, do you ever feel like you have to choose food or medication? Do you ever feel like you don't have enough resources to meet your monthly obligations? Do you have a secure roof over your head? So, and I'm missing one of them, but it's those 6 questions in patient-facing language that they can access through my chart. They actually can, the messages can be pushed out to them. And even for the people who don't have immediate access, most of them are able to be able to do that with their phones. Because even in Hagerstown, some of those couch surfing poor folks have access to a phone that they can actually do that. And so the pandemic probably got more people registered and at a higher rate on my chart than we ever could have done on our own. Everything from testing to immunization to all of those factors. So those questions, that really all of a sudden really helped us to more robustly drill down and to complete that information and capture that information for my chart. We actually also made that available through efforts with MDPCP and being a CTO to all of the community practices that were non-meritus practices as well. So that was sort of what we were doing, both as a health system, but also in Washington County.
So let me make sure I understand there. So you extended that effort to practices that weren't using even your EMR, is that correct?
Correct.
Wow.
So they may have been on a different EMR, but because we were the primary testing site and immunization site and stood up telehealth in a safe way, we were going to spend an entire year on telehealth. And like everybody, we did it in 2 weeks. And just by extending licenses for WebEx to other people that, you had to have 2 screens open, but maybe they didn't have Epic EHR, they didn't have their own telehealth solution, we stood that up and created a lot of community effort through those entities. And then we recently also had that discussion with CRISP, because they're trying to figure it out as well to get to create that solution. Not everything automatically flows in to CRISP with social determinants. I know that's a little different than your initial question with screening, but just an extra thing to add that the CRISP folks have been reaching out to say how can they capture that more and make that more readily accessible for everyone.
Right. And let me That's great. Let me ask Emily a question before she needs to leave. And Emily, when I'm thinking about screening, asking those questions and the way Doug phrased them, it's, you know, very non-threatening, non-judgmental language. What do you think about supporting practices in their screening methods and training folks how to ask the questions and when to ask them, when not to ask them? And is there any effort going on yet with MDPCP to help practices do that?
Yeah, thank you for asking the question. I wanted to jump in. So yes, I think you bring up a good point. You know, not everyone wants to be asked about, you know, particularly sensitive information. Maybe it's interpersonal violence or, you know, even something like food insecurity all of the time, and needs to be asked in a sensitive way. In the MDPCP program, one thing that we are standing up now and will be available a couple months down the line is just technical assistance around both setting up social determinants of health screenings, you know, if it's not in a practice's EHR, to transition to an EHR from a paper-based, or if a practice is using, you know, one of those long screenings that someone mentioned and wants to pare it down or use something more standard. So providing assistance around the screening itself, and also, like you mentioned, how to, you know, how to engage with patients and screen them in a way that, you know, you actually can get some of that information from patients. And of course, sometimes it falls to different providers. Maybe a community health worker would be more effective at eliciting that information from someone if the patient is comfortable with them. So yeah, just to kind of sum it up, we are kind of standing up an effort right now that will be available in a couple of months to provide really one-on-one practice specific workflow support for social determinants of health screenings.
Fantastic. Thank you, Emily. And I know you need to leave early. Let me ask Charles a question. Charles, if we start screening about all these social determinants of health, we start to see patterns emerge in our practice, maybe, or there might be a geographic pattern where there's a site where there's a lot of food insecurity, for example. How do practices that you work with start to kind of collate and curate that data and start to see patterns? Or do they rely on external sources to point the patterns out for them when we're looking at, for example, you know, homelessness or food insecurity? Are they there? You might be mute. Oh, I don't see him. Is he not there? Or he's mute.
Sounds like housing insecurity would be a great parallel term to food insecurity, because I think that would address the couch surfers and those who are living with others. I really like that concept where it's not just I don't have a home, but I just don't have any secure place to live.
Instability, I think, is often used in the housing.
Was that housing instability?
Yeah.
Mhm. Sarah, do you want to comment about that question I asked? How do we start? Yeah.
Sorry, can you repeat? I heard the second half of the question. I said wait for a second. Can you repeat the question?
So as practices start to gather on individuals, social determinant of health data, they might see patterns emerge, or they might want to see where there are patterns emerging so that they can pair need with resources. How do practices look at data that way, or how would they partner with an external resource perhaps that could point out the patterns and also the resources to connect them with?
Yeah, that's a really good question. And I think it is, it can be informed at a practice level, but I think sometimes the more you can look at a population and not just the specific practice, perhaps the better armed you are. So I think, you know, one of the advantages of the CTOs and other infrastructure that different organizations have is that you can start to look at the population served a little bit more broadly, and then really understand what clinics they are being connected with sort of from there. and, and use that to inform distribution of, various resources to meet those needs, for example. So I think some of what, you'll try, I know that we try to do is sort of look at the overall population that we're serving in sort of whatever spliced or diced venue we're talking about, and then use that as an opportunity to overlay some of the resources that we have or the resources that we know that we need and where those can be distributed. And so, I'll just give an example. We have a lot more density of clinics, for example, in the Baltimore area. There are also larger clinics. There's also, maybe more attributed lives. And so how you might think about putting a care management resource in a Baltimore city-based extra large clinic versus, maybe another clinic that's very far away from something else that has a very small attribution, the distribution of those resources is going to be different. So I think trying to think about the population as a whole, and then the resources that you have available as a whole or might need to have available, and then how you can distribute them across the different clinics is, I think, ideal. And then, if you're a clinic as a standalone, it's a slightly different calculation. And then you have to think about, is this an opportunity for me to partner with somebody else to get a partial resource or something else that's going to be most efficient at my individual practice level? Is that sort of getting to your question?
Yeah, and let's go back to Ken for a minute. So Ken, let's say, you start your practice starts screening for social determinants of health, and you start to see a pattern where there's a certain neighborhood where there seems to be food insecurity. How do you go about, or what resources do you wish you had to identify community-based resources that would be helpful to your population? Where do you start?
Well, first, I wouldn't start trolling the data to look for anything unless there was some reason to, and resources to allow me to do that.
Good point.
In the primary care realm, it's got to see the patients to make the money to keep the doors open, and the MDPCP program has been phenomenal in giving us some of that, non-contemporaneous income to have some people who stop and pause and direct resources to where they're needed, currently based, care managed based on direct medical needs. But, if we had a care ambassador to the local community, someone who, works on building bridges, and they had the opportunity to look and assess, where there are those social determinants of health patterns that are in our community, in our population, even if you look at the broader community from a healthcare, large health system perspective, each practice or each site within that healthcare system has their own population, with some unique issues. But, capturing that data, defining which data we do capture, the questions Doug answered were great open-ended questions to get things started, but, how do we quantify those into some specifics that then we can, trend and attack with regards to, whether it's food insecurity or housing instability or transportation. That's a big issue here in our community. Just intuitively talking to people, I don't have data to support that. But I think it's if we ask the questions and then can somehow document the answers in a searchable format, then we could actually then direct resources to address the bigger needs. And I'm sure we'd all be surprised at some unmet needs, some really prominent social determinants of health in our community that we would never see unless we really ask and analyze.
Mm-hmm. Thank you for that. And I acknowledge your wisdom, and don't screen for something you can't address. But maybe what we need to do is enable people to learn about what they can address. And the first meeting, we talked a lot about overcoming mistrust and fear of the medical community. So let's say we do identify somebody with the need and we point them to a resource. What's going to make them say, okay, I'm going to do that? They need to somehow have the endorsement of some community partner who says, yes, this is legitimate, this is real, they're going to take care of you there. Cheryl, how do practices find and engage community partners? That might be the faith community, it might be educational resources, to establish this mutual understanding and respect so that the folks that we're identifying with needs actually to receive that kind of help? How do we find those partners and meet up with them and develop a relationship?
Yeah, I like this question because, I mean, to me, this is where the heart of everything is. Anything that's going to be successful has got to have community coalitions at the heart of it and to have those partnerships. And I don't think practices really have to spend enormous amounts of time finding community partners, because I guarantee in every community, that work is already happening. It's just tapping into what's already there. So, and I think there are, practices can start, I think, by finding out what's already happening and then how to connect to that work. I do think that historically, the medical field has been a little bit separate from some of the other community-based services. And, for lots of reasons, but I feel like community initiatives are hungry for the medical community to be a greater part of the work that they're doing, because all of us see the necessity of that. But I think really, there are some key agencies in every community in Maryland, at least, Department of Social Services, the Bureau of Aging, to name a couple of them that are kind of easy, the Department of Health or local health departments, that would be good places for organizations to start, to find out, to start making those connections to individuals there and start tapping into some of the collaborations that are already in place. And I think that can also help with the trust aspect, because those agencies are going to have levels of trust with patients, just like medical practices do as well. So if we're all working together and patients know we're all working together, it just makes everything go more smoothly. And then, practices have someone to hand off to when they ask these questions and they're, not able to, whether it's time or knowledge or resources, what that may be, to really address those needs that are identified during assessments. I'm not sure, did that answer your question?
Yeah, and I wanted to highlight one thing you said, which I want to make sure I understood you correctly, which was, practice doesn't have to say, okay, I guess I'll go visit some churches and figure out, I got to get some partners. It's more like tap into the local social services department, the Department of Health, Department of Aging, and say, okay, what kind of collaborations do you have going on that I can then tap onto? Did I understand you correctly?
Yeah, because I mean, the work is already happening. It may not be where we want it to be in the end, but let's start, where folks already are, rather than trying to reinvent things.
Mm-hmm. Now, Harka, what would you like to add about that topic in terms of forming community partnerships?
Yeah, so I know you said don't go out to churches and things, but it does take going out into the community. And I'll use an example of a doctor who was on somewhere in Western Maryland in one of our programs. And the way he had set it up was, and he was serving an extremely poor, underprivileged population. And there was no way he could manage to get them medications and have them be healthy with just him. So he was out in the community doing annual walks in which he would invite all the local businesses to partner, and he would invite churches and others to join him in coming out with the community for what was called a health walk. And those businesses and churches and other religious entities then became his resource people. So for example, if in the winter he had people coming over there to his practice with multiple colds and such, and then he finds out that they don't have any heat in their house, right? That's a big issue in the winter, because there are poor patients who simply can't even turn on the heat. So what do you do? Where do you start? So in the city, we have 211 that you can call, but 211 has not been proven, in my view, to really get anybody utility bills that can be covered. But there are always people in the community, such as a church and others, or some foundations, who will donate some funds to him to provide them with maybe like a jacket, things like that. So I think I'm talking about practices that really take care of the extremely poor populations. You do have to partner with the community around you, which includes the businesses, health And then, of course, the structured services through the state and your county, your city, to get them to a place where they can be, I don't want to say reach health equity, but close, sort of get there. So I do think you do have to step out of your practice. You have to be part of the local town center. And some of the local health departments have been developing LHICs, which are these local health, it's variably called innovation or improvement or whatever they want to make that I be. But LHICs are a coming together of businesses, healthcare, hospitals, and others. And I think those are the ways that you can bring these services to your patients. I really do think that's the way.
Thank you. And I know there's an LHIC wherever there's a health department. So that's one other resource. Doug, I'm sorry, you had your hand up, and I know Sarah did too. We'll go first with Doug because he was first.
No, I just was going to jump in. It's really that, just for the comment, more of a closing the loop is really that issue. And I think there's also, besides the local level, which is really important, and particularly to those of us in primary care, but I would say that I think there's bandwidth, whether it's sort of piggybacking onto like a larger system like United Way and 211. It seems like there are lots of groups trying to vie for the space. There's the Intervaser model. There's the United, what's it called? United Us. And Maryland's looking at several of those different models. And I think if we pick one and there's strength in numbers, like we've sort of come together with, with our health information exchange. I think rather than 3 or 4 or 5 models, I think trying to build some synergy from the local level to sort of a network that can be updated in lifetime. I think a lot of times the community health workers and the care navigator nurses are the ones trying to close that loop for us. And we know our communities best, but some way to update all that information in live time to be accurate. That's what I wanted to say.
Absolutely. You only get one chance, right? If you refer somebody to a food pantry, they went on Tuesday and they're closed on Tuesdays.
Right.
Blown it, right? I hear you. Melanie and I were talking about that too. Sarah, please.
Yeah, so I think lots of, I'm trying to lower my hand, lots of really great points there. And I think that feedback loop is incredibly important. Just like any other consult that we put out, you want to know what actually happened or if something happened. But I was originally going to comment on sort of the combination of understanding and not recreating the wheel for the core set of resources that are in each area. And sometimes I think that happens, one community health worker leaves or one person shifts organizations, and all the institutional memory of how we get that person transportation or how we do those things seems to be lost, and we have to rediscover it again. And while the sort of regular resources are wonderful, oftentimes what they learn is like, well, you just have to call Joe at this office.
Exactly.
Can be done. And that's the kind of thing that you really want to have, recorded and understood and known in each little regional pocket to be able to understand what resources are there. But I think the other point about needing to physically go into the community is really important. One, because I think, again, you have to meet Joe so that he can be helpful to you. But I think you also, I think we saw this in our heavy Spanish speaking population and others in our region around COVID vaccines and other things. There is a need to build trust with not only the community-based organizations, but also with the patient population. And so if they see you in a regular fashion, if they see you on their turf, if they see you in their church or in their center, and then you continue to share the same message and to keep coming back, I think it really does do a lot to strengthen the relationship with the community that you're trying to serve. And I think sometimes we just forget, like, oh, well, we're doctors and we're here and we're trying to be helpful and that should be enough. But it takes a whole lot more to really build trust and to be able to get people to open up to you in these areas of vulnerability and to receive, the help that you really are hoping to be able to give them.
Sarah, give us a couple of or 2 or 3 examples of the doc making himself or herself visible in the community in order to engender trust. What does that look like? I won't even give examples.
Yeah, and I don't necessarily know that it always has to be the position, right? But I think it has to be some extension of the care team. I think we have, there's a lot of work here in Baltimore in the churches. There's been a lot of engagements for our primary heavily Spanish speaking patient population. We have the Central Soul. We have places where people are going, essentially the community centers or community engagement places to meet and regularly offer vaccinations, health screening, those kind of things. And so I think those opportunities where you're physically oftentimes moving out of the space of the clinic and going to the communities where people live or to places where they would otherwise frequent, I think there's been a lot of value there. I think churches, again, for heavily religious communities, it's not only being in the church, which they were going to go to anyway, but it's also having their pastor or their priest or whoever it is sort of, I'll get used to the word blessing, but bless what you're trying to say or what you're trying to do, to say that like these are good people who are here for the right things. I remember even in medical school, I think it was sort of newer back then. It's been going on for a long time. The barbershop care, going for health screenings into barbershops where men are gathering, not the best activity for COVID, but I think it's sort of non-COVID times. Again, to just be part of that regular conversation and to, have them thinking about their health at a time when they otherwise wouldn't. And so I think there's lots of different examples. Every community is a little bit different, both in the demographic and where is their gathering place, et cetera. So you can't sort of do the same thing everywhere, but I do think that's the kind of stuff that's really important, to let the community know that you're there and really just interested in their well-being, and not just interested in sort of an RVU pay, like some of the stuff that they start to think about. So just a lot of opportunity when you're physically going out into the community and showing that you care.
Mm-hmm. Cool. And Charles, are you there? I guess not. Okay. I was going to ask Ken, what Sarah was describing, does that sound like something that's doable for the average practice?
If I could take a half day out of clinic to go to engage community partners, churches, health departments, whatever it is, I mean, there's serious financial ramifications for that. It comes at a cost. Some of the large organizations, FQHCs and such, they have funding streams that support those kind of activities, but in the private model, we don't. And you tend to get what you pay for. And so, yes, we need to be in the community. Some of it is just being in the community, shopping at the farmer's market, going to the sports field when the kids are playing, that kind of stuff. Being a visible member of the community builds trust. Also, some of those targeted, engaging faith communities and other organizations as a clinician coming to speak about how we care about the health of those people builds trust over time. But, unless there's a funding stream for this, it doesn't. And I don't mean to harp on this. It's not all about the dollars, but no money, no mission. I mean, that's why that's what leads to burnout. It's that moral injury. I see good that I could do, that I should do, but if I don't do it, if I do it, then it costs me more than I can afford, whether it's my own personal productivity on RVUs or the financial viability of my practice, or, leaving the other patients in my office who have acute medical needs to try to go and invest in, other needs. So you kind of get what you pay for. And I think a lot of these solutions are going to be local. And I would suggest an idea of, let's quantify, let's figure out what social determinants of health we're going to measure. Let's all measure them in our practices, give resources to each practice to, analyze and then develop a plan to address, your local social determinants of health with your local solutions, and, reassess afterwards, sort of the model for improvement kind of thing. Plan it, study it, do it, and then reassess it. I don't know, that's me. I'm an action person.
Sure.
And so, let's measure social determinants of health, see which ones are predominant in our community, give each unique healthcare organization, resources to address that, whether that's personnel or, collaboration or information or, funding stream that they can direct to, hire that community ambassador, or, community health worker to help address some of those. Because this can be different for me in my primary care office compared to the orthopedic office upstairs. They see broken bones all the time from the ski resort. Their community health intervention may be addressing, safety on the slopes and wearing a helmet and wrist guards. Whereas mine might be the, don't avoid your wellness exam because there are good things we check and find there. I don't know, just great.
Yeah, and I think your points are really well taken, and it kind of segues into the fourth paragraph of questions, because I'm going to direct this question to Doug and Sarah. You can pick who goes first, but you are both part of larger health systems that have really admirable efforts in integrating services to the community at large, and even some independent practices and data sharing. So if you think about the small practice and the realities of, gee, can I take a half day off to go meet with so-and-so at the health department, and then we're going to go visit so-and-so else in the community. If you think about that burden, how can we lighten the burden for the practices and make some of our efforts more translatable to them, such that an effort by your health system makes it easier for individuals being cared for by Ken to accept the services and care provided?
I don't have an easy answer. I'll go first at it just because I'm going to have to leave just a little bit before the hour to jump on another call. Sorry in advance. Not an easy answer. I think that we're not perfect at it, but I'd say that we've really had some success, particularly from the MDPCP model and becoming a care transformation organization. I'm not saying that you have to pick the CTO if your local health system has it. I think you have to be affiliated somewhat. And I think you can do that both and remain independent. And that was a large part of the practice on the Pennsylvania side in a different model, and stayed independent until sort of the recent years, and sort of rising in physician leadership. And here we've had some success continuing to grow that with practice transformation. And by becoming a CTO, we could provide those services, because you don't in private practice have the time to go take that time away. And it has to not feel like an extra burden. Those resources have to be readily available for a way that you can connect to them. We can't ask you to do one more thing or check 20 more boxes, right? It has to be that flow to really make primary care be successful. There needs to be advocacy and skin in the game to make that worthwhile to have. If you're going to have some spend of those dollars or accessible, it has to be meaningful, and it really gets us to sort of value-based contracting, where I think we all know we need to go, but we haven't still figured it out any better than anybody else. And I think that there is a way that independent practice can be included with that, as well as group practices. So I know I stayed pretty general, but that's where my mind goes.
Thank you, Doug.
I think that's fair. I think it's increasingly challenging to be a sort of one-man show or one-woman show or one small group show. And I think that works for certain patient populations or in certain regions. Ken, you talked about a more homogenous group, maybe that it makes it a little bit easier in certain places, but I think we are increasingly realizing that you need a full team to do well in the care of patient populations. It is hard to invest. And I think that's what I was saying before, like if you're just looking at one clinic, it's hard to justify an investment unless it's a very large clinic in all of these different types of people who can do these things for you. So I think that, the CTO is one example, and lots of other ways to connect to some sort of broader infrastructure that can make those investments across the system. And the hope is that, when the work is being done to go into the communities, even if it's not necessarily a physician who's trading off billable time, but could be another member of the office or care team or whatever, when they're going into the community, they're representing the broader group of the doctors. And so your practice is one of the groups that they're representing, not just like practice B on that like other corner, sort of to say, we have somebody from your office who's there or something, and to say like we represent all of them. And so I think it has to be a broader group investment. I think there's something about a shared set of goals, a shared set of data, a shared set of things that we're sort of even doing across our state now. Because again, even my health system versus your health system versus another, trying to make that transformation, our patients don't follow those lines perfectly, right? They go across all of our systems depending on the day or where they get sick or when their chest hurts. And so it is the more and more that we collaborate and work together, I think the better off we'll be in terms of actually moving the needle on these outcomes.
Yeah, I'll tell you one thing that, we physicians do well is do referrals, at least in primary care. And with NDPCP, I have a care manager in my office and I can refer patients to her. And she's made remarkable impacts on the health of the people that she helps manage her care. She's the eyes and ears for the clinicians in our practice. And that's targeting some specific healthcare gaps that, were identified to close. And so, if we can identify some social determinants of health gaps to close, and I have someone in my office that I can refer to, or somebody, who gives a valuable, tangible, meaningful service to those patients to help close those gaps, whatever they are. I know they're sometimes a little more nebulous and harder to close, but that's kind of a workflow that works. And then, when I refer, that person does become in some ways a representative of me and the care I'm rendering and that my practice is delivering.
And by the way, I'll just further interject. I think, I shouldn't have to think, oh gosh, this patient is 65 and is Medicare versus Medicare Advantage versus a Medicaid model, that like we have to use this model for all of the payers and all the people, because I think we can prove the outcomes. I'm not going to think differently for those buckets of people. I'm going to think, this is what I want to do for the patient in front of me. And I think, again, that infrastructure helps to support that so that we don't have to be thinking of treating people in different ways. This should be important to all of the work for all the reasons this last hour has brought to light.
Well, maybe this work group and the commission, maybe one of the things they could do is help unify some of these goals that we're all held to, because you're right, Doug, they are so disparate in some ways, and trying to guess which box to check for which program, like, boy, it is maddening.
Right.
Fascinating. What a great discussion, and some themes that I picked up on, and I won't be terribly articulate because I'm doing this on the fly. I guess if I were going to put in one sentence, we've been talking about sharing data, sharing goals, sharing resources, but borrowing strategies, because we all can't just do all this work ourselves. I think there were some really good points made about how to screen for social determinants of health and how not to. And again, the ethical dilemma of screening for something that you can't fix or nobody in your practice knows how to fix. That just points to the need for sharing information about what we can do, which is, again, this roundtable needs to make some decisions or give some advice on what does that help look like for practices. Again, a wonderful conversation, and I'm so pleased to hear your opinions and you share them so openly. It's a pleasure always to see somebody's hand go up. You don't have to work the crowd so much, and I appreciate that as facilitator. I'll turn it over to Melanie at this point.
Thank you, Dr. Zapp. So one thing that I want to ask a couple of people on the line is, how are you guys collecting information? Is it mostly verbal during intake? Is it via an electronic tablet during registration, or are you doing it like online for people? So some of the data that we were talking about in this first point, in general, how is that coming in? So Dr. Buzinski, how are you guys doing that at your practice?
Majority of it currently is coming in just through verbal acquisition or papers we have people fill out. We do have some online portal access, but social determinants of health, IT facility with especially the older population, they can't really leverage a lot of the technology that's available there. So it's asking them in person.
Oh, thank you. Dr. Conway, how are you guys doing that?
I think It varies, but I think much of it is verbal. I mean, some of the stuff like your demographics, that kind of can get filled in, when you're signing up, but I think much of it is, a care manager or somebody interviewing you and inputting that data that's being verbally shared.
And Doug, what's your thought on that about collecting the data? Is he still on?
Looks like he had to jump
Oh,
off.
sorry, he's gone. Okay. Well, I just wanted to ask the question of a couple people, so I appreciate that. So I want to echo Pat's sentiment that thank you so much for sharing your perspectives, because this really helps us to develop these resources to support practices. I don't think that we can solve the issue of everyone asking for a little bit different things, because a lot of those are done by different payers. But what we'll try to do when we come up with a resource is, try to help support those different efforts that are going on through the state, try to take that into account as we develop it. We're not trying to develop something that is necessarily in addition to that. We're trying to develop something that supports all those efforts that you guys are already doing with all those different payer plans. David, I don't know if you want to add to that, and then I'll just make a closing statement about the next meeting.
I would just say, once again, a very lively and informative conversation, and it's a commitment of time to participate in conversations like this. And we're very grateful for the knowledge you've shared with us, and it will help inform strategies to do some interesting work as we move forward related to these topic areas. So thank you both so much. And to the others, we realize, again, some folks had to drop off early. I would give a huge thumbs up to Pat. What an amazing facilitator. So thank you for keeping the conversation going, and to the other physicians, just a huge round of applause. Appreciate your time.
Dr.
Pleasure.
Conrad, did you have another comment?
No, that was applause.
Oh, that was applause. I'm sorry. It looked like I guess I need new glasses. So the only thing that I want to just say is that the recording is going to be up on our website, and then the next meeting is scheduled for June 4th from 1 to 2. So thank you so much again. Oh, go ahead. Okay, go ahead.
Is it June 1st? I think June 4th is a Saturday.
Oh, sorry, maybe I wrote down the wrong day. You don't want to come in on Saturday?
First, it's the first.
June 1st. Sorry. Thank you for pointing that out.
What is it with you today, girl?
I know. So thank you, everyone. I hope you have a great day. We'll be talking soon.
Thanks. Bye.
Thanks.
Bye.